Hello there. I'm Shauna Thome, and I'm the Executive Director of Crowfoot Family Practice, and I'm here at the clinic on a beautiful sunny day in Calgary to show you around.
This is Shauna. She's showing us around the clinic she runs in Alberta. It's a clean and modern space that looks more like an architect's office than a clinic, with soft lighting, modern chairs with shiny steel-tubed legs, and a big curved front desk lit blue from below.
And our reception is so fresh and clean and welcoming. It's calm and modern with comfortable chairs, and I love the big sign that greets patients as they walk in. Even better, I'm greeted every morning by our two lovely receptionists, Shiny and Alora. Now, we call ourselves CVFP for short. And at CVFP...
In October of 2024, I flew out to Calgary to give a talk at their primary care day. And when I did, I asked around, was there an innovative clinic in the area that I could visit? And a few different people pointed me to Crowfoot. Now, I did bring an audio recorder with me to the visit, but let's just say I wasn't the seasoned podcast host I am today. And the recordings, well, they just didn't work out. So lucky for me, Shauna here agreed to give us a tour virtually.
So when patients arrive, our lovely receptionists here, they direct them to an exam room on their color team. So rounding the corner, I start at our blue team. And the blue team has a motto, which is nothing but blue skies. These guys are known for...
Crowfoot was founded in the early 80s, and it currently serves more than 25,000 patients. It's home to 17 family doctors who together work the equivalent of about 10 full-time doctors. And it also has about 85 staff that they hire from the team, including nurses, physician assistants, nurse practitioner, medical office assistants that we'll hear more about, as well as another 10 staff that they get from the primary care network. They're also a training site and support 16 family medicine residents, 15 physician assistant students, as well as medical students and other learners. Now, it's important to mention that Crowfoot is a unique model within Alberta. Since 1999, it's operated as a fully capitated model, one of the only. One of the reasons I wanted to feature Crowfoot on our Primary Focus podcast is because of their approach to team-based care. Now, we've been talking a lot about a future that's different than the current state, one where everybody has access to primary care. And for that future state to become a reality, we actually need family doctors to be able to care for more patients. And one of the ways to do that is by having teams that can actually extend the expertise and the experience of family doctors to larger populations. And here at Crowfoot, they've figured out how to make that happen.
Next, we reach a very unique role here at CVFP, which is our triage RN. This nurse works across teams, handling things like suture removal, B12 injections, urinary tract infections, respiratory infections, and other common conditions. It's a very important role, and it expands access to care for patients, and it helps us run smoothly.
Now, they split their doctors and their other health professional staff into mini teams that are named by colors. These mini teams, they're built around a few family doctors and a registered nurse. Each team also has several medical office assistants who answer phones and prep patients. And then one of these medical office assistants actually serves as a team captain. Now, there's a leadership development program that they have for all team captains. And I should say this type of leadership development is taken seriously at Crowfoot. In fact, all staff have access to a learning and education fund. It's part of how they optimize team-based care.
Each team has a shared workspace where our registered nurses and medical office assistants, they sit side by side, and that helps to make sure they can work to coordinate care and keep communication flowing. And the energy is always lively, and you'll probably hear laughter mixed in with the serious work of care that happens here every single day. So next up is our yellow team. Now, I have to say that every team functions much the same, but they each again have their own flair, and yellow team is always looking for ways to be more efficient and creative. They're like our innovators.
Efficient and creative. It's actually a great way to describe the approach at Crowfoot. And that's why we're on this tour, to see how this clinic is listening to patients, using data, and constantly innovating to meet community needs. Welcome to Primary Focus. I'm Dr. Tara Karen. This podcast is meant to launch a conversation we really need to have about the current primary care crisis in Canada and how we're going to solve it. For the past couple of years, I've been traveling around the world to see how primary care practices in other countries are managing to offer reliable, timely care to their patients. Last season, I brought you with me to the Netherlands in a 4-part series where we broke down exactly what makes their primary care system one of the best in the world. This season, we're launching into a tour of innovative practices in Canada. And today, we're walking through a unique example of team-based care in Alberta that I think has a full rainbow of lessons to teach other Canadian clinics. And after this quick walkthrough of Crowfoot Family Practice and the context you need to know about primary care in Alberta, I'll be sitting down with Shauna and Medical Director Dr. Janet Reynolds to learn how they've built the practice to meet community needs. Now, before we get back to Shauna's tour of the rainbow of teams that work so efficiently for Crowfoot, I want to give you some context about primary care in Alberta. Most family doctors in Alberta are part of a primary care network. These networks were introduced in 2005 to try and improve access to primary care. The networks receive a fee for every patient of every doctor who's part of the network, and the networks in turn use that money to support physicians and patients. Many use the funds to hire other health professionals like nurses, pharmacists, dietitians, behavioral health consultants who work in different family doctors' offices through the week. The networks develop grassroots programs to support the needs of the patients they serve and support team-based care. But while the creation of these networks has been positive for physicians and patients in many areas, it hasn't solved all of the access challenges because not enough patients were actually able to benefit from the other health professionals. There's not quite enough to go around as it stands. From folks I talked to in Alberta, it does seem, though, that it's provided a really important infrastructure for primary care. But at the same time, there's lots of heterogeneity about how these networks operate across the province. There's another piece of context I want to bring in about Alberta. A few years ago, the government launched a process called Modernizing Alberta's Primary Healthcare System, or MAPS. The goal was really to refocus primary care as the foundation of the health system, getting input from lots of different stakeholders along the way. The MAPS process included a separate Indigenous panel as well as a strategic advisory panel. That strategic advisory panel was actually co-chaired by Crowfoot physician Dr. Janet Reynolds, who you'll hear from soon. It published its final report in 2023, and that report included 11 recommendations, including recommendations to change how primary care was organized, how doctors were paid, and recommendations to strengthen team-based care, all with the goal of ensuring every person in Alberta has access to primary care. For example, it recommended new regional primary healthcare networks that are supposed to provide services to everyone in the region, not just people who are lucky enough to have a family doctor. Now, up until recently, most family doctors in Alberta were paid fee-for-service. But as of April 2025, family doctors are being paid in a new way. There's still some fee-for-service payment, but less than before. Instead, there's now an hourly payment for both visits and behind-the-scenes work with a higher rate for care after hours, a set payment per year for attached patients adjusted for complexity, and a 10% payment for administration, which Shauna says they see as an acknowledgement that to run a family practice, it takes a lot more energy, effort, time by the physicians and their staff. This new payment model, it's meant to fairly compensate family doctors for the work they do, including work that happens outside a visit. And the hope is that it'll attract more doctors to community-based family practice. Now, if you want to know more, I chatted about these types of changes in physician payment happening across Canada with Dr. Ruth Laverne in our last episode. So far, Shauna says there's been a high uptake from family doctors in Alberta on this new payment model, but many are still skeptically optimistic. But as I said before, Crowfoot is unique. These funding changes don't affect the clinic because the clinic's been operating on a fully capitated model since 1999. That means that the clinic, not individual doctors, receives a set amount of funding per patient per year. And when one of their patients seeks care outside of their office, say at an urgent care center, a walk-in clinic, or an emergency department, there are financial penalties for the clinic. And so that means Crowfoot needs to take extra care to ensure that patients can access care when they need to. And now let's get back to our tour. As Shauna says, each patient at Crowfoot is assigned to one mini team. And that team is responsible for offering primary care when and how the patient needs it. For example, if patients have an urgent issue, they call their mini team to get a same-day appointment.
Next up is our green team. Now, CVFT is a teaching clinic, and while education happens everywhere here, green is where you'll find the most learners. Each year, we welcome up to 15 family medicine residents and another 10 to 15 physician assistants.
Where Crowfoot stands out is how they optimize their systems, so every member of their team, whether a doctor, a nurse, or a member of their office staff, is supported to work at the top of their scope.
Next, we have our gold and silver teams. Now, these were created back in 2010 when we expanded and took on 10,000 new patients. And that expansion, I have to say, was huge for us. We recruited 6 new physicians, 20 staff, and it was a brand new chapter in our history. Today, in 2025, we've grown to about 140 staff and providers, delivering care to more than 25,000 patients across Calgary and the surrounding area.
Crowfoot's doctors focus on more complex care and consultation, while other team members handle more straightforward issues. In fact, between 35 and 40% of care at Crowfoot is delivered by non-physicians. Registered nurses are a big part of that. They triage patients, provide preventive care, manage uncomplicated conditions like bladder infections and sore throats. And Crowfoot's health management nurses take on chronic disease management for patients with hypertension and diabetes. Now, these team members are funded through 2 different streams. Pharmacists and health management nurses are provided through the primary care networks. But the registered nurses and medical office assistants, they're paid for through the capitation payments that come to the clinic. The cost of these team members has to be offset by the efficiency gains in doctors being able to care for more patients. And this team, they figured out just how to do that. Physician panel sizes, that means the number of patients formally registered with a doctor, they're about 30% larger at Crowfoot compared to other physician practices in Northwest Calgary. Shauna says historically, they've aimed for a physician to have a panel of between 250 to 300 patients per half-day worked. Now, Dr. Janet Reynolds, she works 2.5 days per week, and she has a panel of 1,800 patients, so she's considered over-paneled. But she has a practice partner who is given less patients on purpose, so that together they have a balanced workload. They share about 3,000 patients together and work a combined 5.5 days per week. Now, we've talked about how the clinic is fully capitated with payments for each patient going to the clinic as a whole. But I should mention that the clinic pays Crowfoot doctors mostly via an hourly rate for the time spent on clinical work, but also for the time spent attending meetings, doing paperwork, and teaching. Doctors also get some pay based on the size of their panel.
Finally, our newest addition is the Rainbow Team. We call it Rainbow because that pulls from the brilliance of all of the color teams at Crowfoot. And the Rainbow Team is built around collaboration. So 4 registered nurses and a physician assistant and a group of navigators who are all medical office assistants. They work closely with a family physician, and it's a model designed to expand efficiency and rethink the physician role into more of a mentor and a guide supporting true team-based care. In the past year, the Rainbow Team has taken on 1,600 patients, and many of those folks from our community did not have a family doctor previously, and we're learning so much about how this model works. So the tour doesn't quite stop there.
At Crowfoot, they also really understand the importance of patient engagement. Patients don't just receive care, they help shape it. They have a patient advisory committee, which provides patient perspectives on developing and rolling out new initiatives, like the Rainbow Team you just heard Shauna talking about in our tour. Linda Anderson is one member of the patient advisory committee.
My name is Linda Anderson, and I live here in Calgary. I worked for many, many years with Alberta Health Services in pediatrics, primarily with mental health and child abuse. And I retired about 4 years ago, and unfortunately went right from retirement into illness, and I was diagnosed with cancer. Very fortunately as well, I have been very well treated. The surgery and the treatment went very well. And at that time, I was also in the process of trying to find a new physician. So I was told about Crowfoot Family Practice, and that it was a very good practice, and I put myself on a wait list. And that's how I sort of got in touch with them, and was contacted and asked if I wanted to sit on their steering committee to develop the Rainbow Project.
For Linda, she says that as a member of the steering committee, her personal aim is to always provide a perspective of both the patient at Crowfoot, which she is, but also as someone who's worked in healthcare.
I think when you're in whatever your business is at the time, you lose, I think, sometimes sight of the fact that there still are people there that are scared, are feeling very disconnected, not feeling supported. And when those voices are heard, I think people can feel, yeah, you know what? We're all going to benefit from this. And they are hearing me, what my needs are. So it's not just about the bigger system, about how can we do this for less money? How can we do this quicker? How can, it's still about how can we meet the needs of those people that we serve? And I'm so impressed with the family perspective that they have here, that they treat the individual, but they also appreciate the bigger family system. When we met as a patient group, I heard that over and over again from other people. I'm by myself up here. The rest of my family is not connected to the clinic, but I heard that through other people, and that their physicians, they've cared for their grandparents, and they've cared for their children, and they've cared for that whole family system.
Linda says to have a clinic like Crowfoot listen to their patients and then actually use their insights to drive change is special. For example, when they launched the Rainbow Team, a working group of patients acted as the guinea pigs for the pilot, and their ongoing advice and feedback based on their real-time experiences allowed the clinic to iterate and make changes to the process as they built it out. And with her patient hat on, Linda says she feels really lucky to be attached to such a meaningful practice.
No, I just feel like I've landed in a warm space. And as I was leaving the acute care system and things were getting better for me, I did have a fear that accessing service was going to mean I had to go to emergency care. And I don't feel like that. I feel like if there's things that come up, I have a place that can address those issues. And I know that I've heard other patients say that as well.
And she says if she had one piece of advice to other practices who are wondering whether to take on a team-based approach like Crowfoot, it would be,
do it. It is so beneficial. And I think even other disciplines, what they can contribute, what they can add, not only for the patient, but I think for the entire team. That there's a lot of value in a multidisciplinary approach. I think this is the way to go.
Crowfoot is obviously a special place. And that's backed up by the numbers. An evaluation done by Health Quality Alberta found that Crowfoot provides more cost-effective care than other practices in the same community, especially when downstream health system costs like emergency use and hospital stays are taken into account. They estimated that in 2016, Crowfoot generated health system cost savings of about $4.3 million, and that the trend of health system cost savings was consistent since about 2007, which translated to an estimated 10-year accumulated savings of about $57.3 million. Those are incredible numbers to consider. So, to learn more about how they do things, I sat down with Shauna and Janet a few weeks ago over Zoom. But before we jump into that conversation, I thought I'd have them formally introduce themselves.
Okay, well, thank you. I'm Janet, and I am a family physician here at Crowfoot Village Family Practice, where I work part-time on one of our teams, and I get to function as the medical director for the clinic with Shauna, my dyad. And then I have another leadership role in the system as medical director of what right now is the Calgary Foothills Primary Care Network, which is the network in Northwest Calgary. So we're the only PCN that has a rural component with our urban. And we have over 100 family physician member clinics and nurse practitioner member clinics. We support with centralized and co-located health team pharmacists, health management nurses, so team that go into these primary care practices and support patient care. And then centrally, we have social work and registered dietitians and health team for all patients, whether you have a family physician or not.
You're also the co-chair of the MAPS process.
Oh,
So Janet wears a primary care network hat, a Crowfoot hat, and a provincial hat. So the lenses are many and broad.
And this is Shauna Thome, who you've already met.
So I have the great privilege of working in a dyad with Janet. And Janet and I have known each other for 15 years now. So I am the executive director of Crowfoot Village Family Practice. I joined the clinic 15 years ago, almost reluctantly. I used to work in the acute care system here in Alberta Health Services, and I expected my career path to really expand there. But I took a meeting with Crowfoot to learn about what the executive director role was. And I, again, very reluctant, but I left that first meeting feeling like this was in complete alignment with the leader that I wanted to be and the system change that I really saw for Albertans, for myself, for my own family. And I never looked back. So Janet is sort of the clinical brain. I'm the business brain. So my background is entirely business. And together we always say we basically make one whole brain.
Yeah.
It's this brain of the operation that I wanted to pick about how Crowfoot has figured out how to optimize the team they work in, and how they use data and patient feedback to really deliver high-quality, timely primary care. It's also why Shauna and Janet joined this interview sitting right next to each other in their clinic. They are truly a team. Here's my conversation with Janet and Shauna on Crowfoot's unique model and the innovations and access to care they're pioneering in Alberta.
So Janet, I think one thing that you mentioned to me when I've spoken to you before is that you say, this team-based model, partly what it requires when we think about working to top of scope is not just, nurses or pharmacists or social workers working to top of scope, but physicians working to top of scope, and that can be a mindset shift as well. And I wonder if you could speak to that.
Yeah, physicians are human. No surprise there. And so sometimes we crave something that's easy and uncomplicated because of the cognitive burden. Mm-hmm. Often when something you think might be easy on looking at your day sheet turns out to be a multiple concern visit or actually way more complicated than you thought. And so we need that break. But I think if we design our work to give those breaks to physicians, our physicians all know that they're not going to be seeing just one person for a wart as an example or something that's really straightforward. They're supported by each other and the rest of the team around knowledge gaps as well, because we are seeing the most complicated patients. And nothing is so black and white that I am not wanting you to think that every patient needs 1 hour of my time because they're so complicated, because we are booking 15-minute and 30-minute appointments. But I don't come to work wishing I could have a straightforward viral upper respiratory tract infection. That doesn't work well for our system, because that means someone who needs me more can't see me. So it's really about maintaining access. Yeah.
I want to go back to that point you made that it's hard to keep seeing hard things. If your whole day is hard things, that cannot feel good. And so how is it that your doctors have been motivated to have a practice style and a team-based approach where it sounds like most of the time when they're working, they are seeing the more complicated folks that are coming through the door?
I don't know if it's as simple as this. So Janet, jump in.
Yeah.
But I think, again, part of this team-based care model is it's really important that we know who we are, that we know what we're doing and what our place is in this health system that Crowfoot has established. Like, it might sound very businessy, but vision, mission, values, the way that we work together.
Yeah.
And that when we recruit people and when we attract people to our team, that we're looking for like-minded people who find this work extremely rewarding, who for them, yes, you're going to see tough patients, but and you have immense trust that you're supported always by a team, that you're never delivering care alone, that you always have the opportunity to collaborate, that you can delegate. And I think the people that we have on our team just having a team behind you and knowing you have that support really helps sort of reduce that cognitive burden. And that's not to say that folks don't have hard days here and that we see hard cases. I think that's quite frankly present all through primary care. But I think there's something sort of psychologic and there's a safety in knowing that we're in this together.
And I think we very much value when you're not here, you're not here.
Mm-hmm.
That is a break.
Yeah.
So I have Dr. Benedictson who does my inbox when I'm not here. But when people take vacation, the panel's covered, you don't come back to anything. Your patients have got seamless care. So we really do value and promote breaks. Mm-hmm. And that's very supported. And I would say it's not off the corner of our desk that we create our culture. So we have regularly scheduled meetings. We do retreats. I think there's like the little bit extra that makes people feel like we're all rowing the boat in the same direction.
So much of what you're saying makes sense. Of course, we need to create culture and environment where people understand who they are and their contributions that are unique in the relative to the broader team, and what's needed in the community. At the same time, I think I hear you saying, you're recruiting for a certain kind of person, but if we want all family doctors to work in this way, it is going to be a mindset shift for everyone. We don't have the luxury of saying, okay, you can work this way and you can work a different way. So yeah, I just think it's something that we need to challenge ourselves to think through, as a profession. But I wanted to also just shift now to, I remember when we met before, you told me, we talked about this challenge of people not having access to care. And there are many people within your network, I think, who don't have any access to primary care. And I think your clinic feels like an obligation to try and support as many of those people to have care as you can. And so tell me about, I know you've been doing some innovation. I know it has something to do with the rainbow. But anyway, tell me a little bit more about that.
So when you were here in October, we definitely were feeling like we had a wait list of 4,000 families. We were working to try to create capacity to attach unattached patients into our model. I would say that, again, some of these system changes that we're seeing, including a new funding model that offers physicians more stability, we're starting to see a shift in that. I don't know what the number is, Janet, but I think it's about 60 physicians in our area of the city who have opened practices in the last 6 months and taking new patients.
Oh, wow. That's hopeful.
Again, we're a pocket. So I'm not saying that's what's happening across Alberta by any means.
It's not.
It's not.
Yeah.
But it's happening where we are. So what started as an opportunity to create capacity for our community is shifting. What we developed, I'll start there and then I'll talk about how it's shifting. We wanted to design a team that was maybe less reliant on the physician. So how we really looked at things is in our original teams, the physician is still essentially the first point of contact and the person who makes the decision about how the patient accesses care and who they access. And so it felt like a bit of a bottleneck and a potential delay for patients. And again, was heavily reliant on the physician. And so we've redesigned care so that instead of the physician being that first point, that they're actually more acting as a consultant and a support to a broader team. So the 6th team that we have at Crowfoot is designed a bit differently. It has 2 full-time registered nurses who have advanced scope of practice. It has a full-time physician assistant, and then it has a physician working about a 0.2 or 3 FTE, which is significantly less, to support a team that will ultimately be about 3,000 patients. And so the physician assistant and the nurses work together to do patient intakes, assess, and then get patients attached to the right provider on that team. They do it in consultation with the physician, so the patient care is always safe and still attached to the right person, but it just broadens our options in terms of attaching patients. And it also allows us to employ more people in our community, and again, not be so reliant on the position of a physician. And as well, it's rewarding for a physician because now I get to work with a broader team of people doing different kind of work where the physicians are still seeing the most sick patient, but they're spending a lot more time coordinating with the team, mentoring, supporting, coaching, etc. So this is in its early days, I would say. So we've been doing this for just over a year and a half. So we're still learning. And again, the system around us is evolving. So now what we're seeing is it's less about being motivated to create capacity, although that's still very important. And now what we're really looking at is a model of care that is sustainable from a cost perspective. So we really want to make sure that we're using those precious public dollars as best as possible. And so we're interested to see if this model, which focuses on the lowest cost provider working to highest scope of practice in collaboration with a physician, also lends some sustainability, viability, and again, that really just being thoughtful about how those dollars are invested and what we learn from this team design and how that might relate to the other teams in the clinic.
I mean, what I love there is like your ambition is to have like 3,000 people being looked after by a physician who's actually only working there like 2 to 3 half days a week, but is acting as a consultant. So a family doctor is kind of the consultant to this team that day to day is actually looking after the needs of those 3,000 patients. That's quite ambitious, I would say, in terms of the numbers that you've laid out. How has it been going so far? And what has been the reception from the patients who you've taken in from that model?
This team couldn't function on its own without the larger team supporting, because those patients might get sick and need to be seen just like any other CVFP patient. They would have access to the rest of the team as well. So it isn't just an isolated pocket, and that's really important. There's definitely, a minimum cohort of people that need to share the workload a little bit. That's important to note because, if a patient on that team needed to be seen and there was no rainbow physician that day, they could see any one of the other 8 physicians that have access to appointments.
Yeah, so I hear what you're saying. So like that consulting physician is responsible for those chronic ongoing needs. But you guys have cross coverage within your team that everyone is a beneficiary of. So all, your 25,000 patients can always be seen by somebody else in the team if their most responsible physician, for example, is not there.
And you're right, it is very ambitious. And again, we're still learning. So I think one of the things we're paying attention to is right now we're in a process where we're intaking those patients. So we're learning about them. Some of them have not been attached to a provider. What was very interesting about this process is we actually surveyed patients on our wait list while we were designing the team to see if anecdotally from patients, we could understand their perception of their health needs. And would that help inform the composition of our team? And what we got back from patients who responded was, I'm well and healthy. I simply want to be attached to a family physician. And as we took patients on from the waitlist, we've taken on just over 1,000 so far. That is actually not the case. We've revealed a lot of maybe asymptomatic chronic disease. There's been a lot of things go on. So the kind of care where you're taking patients who are in the community and not receiving consistent care and weren't attached to a provider, that's different than actually just managing a panel of patients who is well managed and well cared for.
It takes more work when you're taking on people who haven't had care for a long time. But I think what I'm also hearing is just like some people who were out there in the community and thought they were well actually weren't as well as they thought that they were and would benefit from some chronic condition and preventive care.
That's right. So we don't exactly know what the composition of the team will look like once the team is sort of through that intake. And so I think what we're learning is what is the right FTE, how is this team going to function? So we are also very fortunate at Crowfoot that we have a director of quality improvement on our team, Dr. Karen Siegel. She is a family physician who is retired from practice, but she is also an epidemiologist. So in any of our quality improvement initiatives, and we would consider our Rainbow team as currently a quality improvement initiative, she's working with us to look at all of the data, including experiential data from patients and from staff and physicians.
Tell me about that experiential data. Tell me about how patients are finding it.
First of all, we had patients involved in the design of the team. We did focus groups before we even started to test these theories. And we had people who came into the focus group very skeptical who left saying, why isn't everybody doing this? And, I think we all know that personality match, like you can't be everything to everybody, but it's overwhelmingly positive that people feel grateful to be attached, very open to not only seeing a physician once they understand role and scope, the concept of that sharing the halo. We're moving people away from the very traditional, no, I need to talk to a doctor for everything. We have lots of patient quotes. We have provider satisfaction that's off the charts, I would say. We go through our health team effectiveness survey to work on any areas of improvement.
And Janet, just to interrupt you, are you talking actually about the rainbow team, or are you talking about everybody all together?
Yeah, we measure it with every team.
Well, I'm speaking specifically to the rainbow because it's different.
Yeah.
So that the patients are much more engaged, I would say, in their care right from the beginning.
And I think one of the very important things to note is this is different, right? When you think of mental models and the way that a patient, any of us, are really sort of trained, socially trained to expect primary care, most people think, I need a family doctor.
Yeah.
And anything else is sort of very strange because nobody taught us how the health system works or how to navigate it. And so one of the things we do is we have a lot of intentionality about this. So we bring patients with us. We have a formal orientation program where patients join us over a Zoom and we present the concept and we talk to them about how it's different. And then we have an open Q&A and we host those in forums of about 50 patients, voluntary, of course. And we've also taped a video for existing Crowfoot patients to talk to them about how we see care changing in the clinic. Interestingly, the Rainbow team is comprised largely of patients from our community who are unattached, but they have also helped take on some patients from within Crowfoot. We had a physician retirement last year where we did have some difficulty recruiting a direct replacement. And so we're moving patients over to this new service. And it's interesting that the patients who come from the community are so thankful to get care and very open to this. The patients who've experienced sort of the traditional care model at Crowfoot are having, in some cases, a bit of a tougher time adapting. So, our team is trained on how to walk with them through that and sort of allow them to experience it and build a little bit of trust that it might be different, but you're still going to be very well cared for.
There was so much to love about what you just shared, including, all of the measurement you've done, all the understanding your work you did before you launched this new initiative to figure out what was the new initiative going to look like and what would people receive well, both people who were working and people who are receiving the care. And then also all that measurement just to understand, is that actually working out the way you wanted it to? And through all of that, it sounds like the patients were kind of at the forefront of helping you design it and also helping you to understand if it's working. One of the things I love about the work you do is that you do it in partnership with patients. And I understand you guys have what I think you guys call a PEP squad. And I wonder if you could tell us a little bit about the PEP squad.
So it was a couple of years ago, our board, the owners of our clinic, sort of thought we talk the talk, but we aren't walking the walk around patient engagement. We're very patient-centered and patient-focused in the care we deliver in the moment, but do we have patients involved in the design? And so we put out a call to our patients for being patient-engaged partners, or PEP, be on the PEP squad. And we really did think we'd be lucky if we had about 20 people respond. And I think we had over 130 on the first call. And now we're up to close to 300 patients. And so anytime we are thinking about an initiative, we may send out an email blast asking for participants, or we may pick a demographic of patients that we want some feedback on, and we'll do a project with patients involved. And the first project was our patient guide. It started out as a new patient guide, but we realize it's for all patients, not just new patients, and helped with the design of the information, what they would like to hear and need to hear from us, not what we want to tell them. So it's not like the Crowfoot rules of how you get care. It's what patients might need to know around how to access care. And that was our first project.
The most recent project is actually we've just launched an internal patient feedback program.
Oh, yeah, good one.
Recognizing that it doesn't always feel safe for patients to deliver feedback on their experience, especially when it's constructive feedback or it didn't meet their expectations. And so we've developed a very simple program. It's a secure web tool with 3 very basic questions about your care experience today. There's a QR code in every exam room, in our waiting room, on our website. And so patients are able to send in notes about their experience or questions.
Yeah.
And for the most part, what we get is, lovely and great feedback about some of the things that they're experiencing. But we've also had constructive feedback that show us maybe where some of our gaps are in bringing patients with us in their care journeys. And they've allowed us to meaningfully engage with individual patients to learn more about their experience and where we might be missing something.
Yeah.
We've just launched that. So we've got about 3 months of experience with it. So again, still more to learn, but that was completely co-designed with our PEP Squad.
And we've had patients from the PEP Squad in other quality improvement projects that are more clinical, like our blood pressure initiative. This has been a big learning for me. So when I'm feeling stuck as where are improvements needed or how do we make an improvement, pausing and asking patients, because they're the receivers of our care, has been incredibly powerful and actually not scary at all.
Yeah, that's been my experience as well in my own work. I really started to get more deep into engaging with patients in my work, both at a clinical setting to improve the care clinic delivered, and then in research, probably back in like 2015, 2016. And I remember people also feeling very worried that if they worked with patients, what they would hear were like a lot of criticisms or unrealistic demands that they wouldn't know what to do with. And I found myself when we were actually working with patients, it was actually people are very reasonable, very thoughtful, and also extremely grateful to be cared for in the settings that we're caring for them in, and wanted to contribute in a really positive way. And so my own experiences with patient engagement have always been very positive. And then to your point, Janet, what I always love is that they challenge my own thinking, because there's been many a time where I've walked into an engagement predicting what I might hear and then actually hearing something very different than what I expected. And there's no way I would have predicted what I would have heard. I couldn't have done that.
It's really interesting to navigate the health system as maybe a quote unquote expert, where you experience it from the side of delivery. And then it's such a privilege to talk to a patient where they offer you their authentic experience in a way that's so constructive that you can co-design.
I mean, I think when I reflect on our conversation today, I am actually also reflecting on some of the priorities that were put out by the Modernizing Alberta Primary Care Initiative, MAPS. And in there, they talk about embracing patients and citizens as partners to empower people and communities around the primary care system. And then they talk about accelerating efforts to ensure every person in Alberta can be connected to a patient medical home that provides team-based care. And, I think you talked so eloquently about how that wasn't really the case in Alberta 20 years ago or 10 years ago even, and now it's happening more and more. And we talked, about quality and governance and things like that, and culture, organization, culture, payment. I guess just like as we close out, I wonder if you have, any further things that you wanted to share related to the clinic, the work you're doing there, but also maybe how your clinic interfaces with the primary care network and the broader province, and, what the other networks or provinces and people outside of Alberta might be able to glean from the work you do.
I would say that we are always open and early adopters of any service that might fit the needs of our patients. And you had asked the question earlier around if we had any involvement in the hiring of these staff that come work with our patients in our EMR in office. And we don't, but we have some really great processes and role clarity on the role of the physician and the clinic versus the role of the primary care network and how we work together. Because we are all a piece of a very complicated system and can't do this alone. Mm-hmm. Maybe that's a different podcast around the detail around the relationship between primary care networks and the member clinics. The other thing that Shauna didn't talk much about yet is we were a one of one in Alberta for a long time.
Yeah.
You know, that was a blessing and a curse at the same time because, oh, you're Crowfoot, you're different, you know, and that was sort of a reason to stall progress, I would say, for others, because others felt like this is not accessible to them because they're not Crowfoot. So what I would say is we have a lot of outward facing advocacy. And I hope it's with humble authenticity that we're open to learning from anyone else as well. When you came, you say you really liked the visit and were blown away by the care we're providing. And we were equally as blown away by the research work and the Our Care interviews that happened across and the structure and all of that. So, but we do a lot of advocacy. We will sing from the rooftops what we're doing if anyone would like to listen. That includes with bureaucracy, politicians. It's strategic and it's not a coincidence, you know, at all. You kind of make your own luck sometimes.
You read my mind.
Yeah.
I think how I would describe it is there are pockets of brilliance all over this province and all over this country. We occupy this, you know, we're so fortunate to occupy this little corner of the world and have the funding that we do. And one of the things that we're constantly talking about is scalability and spread. And when we have this ability to learn, and I call it a petri dish, but Janet calls it a test kitchen.
Yeah.
We get to build all these really neat things with our team, and we have protected time to do that. So we engage with our community to kind of share what we learn and talk to them about how things might be adapted. And we learn something from everybody that we engage with. So I think we're a learning organization too, and we recognize that we've been doing something for 25 years, but there's still so much more to learn. And we do protect time to engage with folks from all over, certainly Alberta and even in Canada, to co-collaborate and do cross visits, cross-pollination of the brilliance that's happening everywhere.
Well, I will say that, you know, based on what you've told me today, I mean, I think there's a lot we can learn. I'm situated in Ontario and we do have teams here, but I don't think we've I don't think we have universally been successful in structuring our teams in such a way that the whole is much greater than the individual parts. I think in particular, I don't think that we have cracked that nut around how can a team really enhance physician and NP capacity to be able to care for more patients so that, you know, more people in Ontario and in Alberta and across the country have care. And I think what you shared today was some wonderful pearls about the approach that you have as a team to be successful in your work and create a positive environment, and also the details around, you know, what it is that you do on a day-to-day basis and different people do to actually make it work so that, you know, physicians can care for more people and more people can get care within a setting that can deliver the full scope of primary care, even if that's not seeing a physician every day. And what I really love too was just the patient and public partnerships that you've taken on to really help design the care that you deliver continually improve it, both through the feedback of patients and also through your attention to detail and data.
I've been reflecting on this conversation, and I think there are a few things that clinics in Canada can take away from what it is that they do at Crowfoot. I think it starts actually with the deliberate development of shared mission and vision and values that really align the entire team around their joint purpose. And then they don't just take teamwork for granted. They are actually continuing to develop their team from a leadership capacity to ensure people work well together. Roles are really defined, and they're complementary, not duplicative. Everyone is working to top of scope, and that includes family doctors. It's really interesting to me how family doctors on this team are often working as consultants, seeing really some of the most complex, challenging cases, but in a way that's supported so that, you know, when they're not in clinic, for example, they can really take a break. And when they are in clinic, they know not everything is just on them. They've got a whole team caring for the patients. And of course, Crowfoot is not okay with just maintaining the status quo. They're always looking to change, innovate, and do better. They're collecting data, looking at data from their electronic medical records, from other sources, but also specifically getting feedback from patients to help guide how it is that they should do things differently, how it is that they can be better. That kind of dedication to continuous quality improvement, I think, is something that all teams would benefit from. A huge thank you to Shauna and Janet for welcoming me to their clinic back in 2024 and for agreeing to be interviewed again for this podcast. A special thanks to Patient and Steering Committee member Linda Anderson for sharing her connection with the Crowfoot Village Family Practice with us as well. I hope you found this conversation just as inspiring as I have. If you want to know more, head to our show notes where we've included some photos of the Crowfoot Clinic as well as some resource links. Primary Focus was created by me, Dr. Tara Kieran, and is made possible by a grant from the St. Michael's Foundation. Miriam Dinesh is our research coordinator. Seema Marwaha and Emily Holton are our creative advisors. Our producer is Avery Moore-Kloss. For more information on the Our Care Standard and the public's vision for a better primary care system, visit ourcare.ca. And if you'd like to read more content from me about Canada's primary care system, give me a follow on LinkedIn. I'm really hoping you enjoyed this episode, and if you did, we'd really appreciate it if you could send it along to a friend or a colleague. And don't forget to give us a follow on your favorite podcast app. We want to spread the word about how to build a better primary care system, and we really think it's going to take all of us working together to get on the same page and raise our imagination for how it is that we can do things better. We'd also love to hear ideas from you or comments about what you think about these episodes. To do that, just email primary.focus@unityhealth.to. Family doctors listening to this episode, you can claim MaidPro credits by completing a linking learning exercise. Just see the show notes for more information. The information shared in this podcast is for educational and informational purposes only. It's not intended as medical advice and should not be used as a substitute for professional medical care, diagnosis, or treatment. Always consult with a qualified healthcare professional before making any medical decisions or changes to your health routine. The views expressed in this podcast are those of the speakers and do not necessarily reflect the views of any organizations I may be affiliated with. Side effects of listening to this podcast may include a strong impulse to help fix the primary care crisis in Canada, a feeling of anger over how many Canadians do not have access to primary care, increased feelings of empathy toward primary care professionals who are just trying to make it work, and intermittent visions of hope that we can find a better way.